Very warm welcome to our South East Maternity and Neonatal Spring 2 Learning and Sharing webinar with a focus today on celebrating good practice. My name's Charlotte Easton. I'm a Senior Quality Improvement Manager in the regional team, and I'm delighted that you're able to join us this morning. So as with all of our learning and sharing webinars, we record them and upload them to our website. So if you could please mute your mic unless you're presenting or asking a question. You can use your raise your hand function to raise a question or make a comment. It would be great if you can introduce yourself at the time. Again, you can use the chat function to share your comments and reflections in the Teams chat, and it'd be great if you can introduce yourself and you can ask questions there as well. And I've got a couple of colleagues on the call who will be monitoring the chat for me. Thank you. And the links there, we'll be sharing these slides afterwards where you can access the recording and the slides. So we do have a slight change to our agenda this morning. Unfortunately, one of our speakers isn't feeling very well and is unable to present. So we've got two fantastic in-person presentations from Jasmine and Amber and from Angela. And then we have a video presentation from Rosie, who's on leave today, but has very kindly prepared her presentation for us. So for those that are midwives or working maternity services, it probably wouldn't have escaped your notice that last Tuesday was International Day of the Midwife, and it's been incredible hearing about all of the wonderful things that you've been doing. I'm starting to collate the photos of all the events that have been happening across. We've had Bake Off, we've had conferences. There's a conference this Friday in one of our trusts, and I presented at a couple of events as well. So it'd be great if you have taken part in some celebrations. Feel free to use the chat. Tell us what you've been up to and share all the work that you have been doing. But I just take this opportunity to say a really, really big thank you to all of you who work in maternity and neonatal services. The work that you do is absolutely critical and valuable, and it's very much appreciated. So thank you very much. And today is International Nurses Day, so 7 days later. So again, a huge thank you to our neonatal nurse colleagues and our nursing colleagues who work in maternity services. Without you, we'd be really struggling. So I've loved working with nurses in maternity when I've been clinical myself, and I think you all do an absolutely fantastic job. So I just wanted to take this opportunity to wish you a happy International Nurses Day as well, and hope you have fun celebrating. Again, do share with us what you've been doing in your local areas as well. So let's move us on to our first presentation. So I would love to introduce Jasmine Conway, who's one of our maternity support workers, and Amber Clark, who's the infant feeding lead, both from Oxford University Hospitals NHS Trust. And Jasmine, I know you want to share your slides, so I will stop sharing.
Hello.
Hello, we can hear you.
Hi there. Sorry, technical difficulties this end.
You're doing fantastic.
You are.
Bear with us. I'm just trying to share.
Do the present in Teams again.
So we go on to and we present in Teams. Oh, sorry everyone, my camera's not working either. Here.
Don't worry, we've got time.
Fantastic.
Here they come. Lovely. We can see your slides there, and hopefully you can see your notes at the same time.
Fantastic.
Yep, over to you.
So good morning, everyone. My name's Jasmine. I'm a maternity support worker in the infant feeding team at Oxford University Hospitals. Yeah, fantastic. Today I'm going to talk about who we are and what we do, our EDIS session, the digital session, and answer any questions you have at the end. Our team is made up of midwives, maternity support workers. Sadly, I'm missing Maddie, my wonderful colleague that you'll see in the digitalised videos. She's on maternity leave now. We're a specialist team with a wealth of knowledge and various qualifications. 3 of our team are international board certified lactation consultants, 2 of whom are qualified tongue-tie practitioners, and we have the only flange fitting expert in the UK. I've just put on the screen just a small sort of a glance at what we do. What we do is huge, and we make a massive impact. But I've just touched on it on the screen. So if I just touch on a few, we offer complex feeding support. We deal with faltering growth, at-risk babies. We write lots of feeding plans. We escalate concerns, so we have a lot to do with other colleagues on the wards. We do a lot of one-to-one support on the phone and in the community. So we pretty much deal with everything feeding related. And there's a small photograph of part of the team that we could get together. Just take you to the next slide. So Edith, our early days information session is delivered on the postnatal ward. As a maternity support worker in the infant feeding team, I'm based on the postnatal ward, but I can give support to patients and staff anywhere on the hospital site. The infant feeding team run the early days session every day on the postnatal ward, and that's for any inpatients. We teach responsiveness, reading babies' cues, the importance of skin to skin. We talk latch attachment positioning. We talk about both breaths offered, compressions, minimum of 8 feeds, hand expression, stomach sizes for healthy term babies. We talk to patients about the 4 reliable signs that parents can tell if the baby's getting enough milk: suck, swallows, milk transfer, poos and wheeze and weight gain. Most importantly, where to get the help in the community once they leave the hospital. Just take you to the next slide. So, as I said in this slide, we had to find a way to make the session accessible to everybody. Obviously, there's lots of patients that they can't get out of their beds. They've been through so much. So we wanted to make the session digitalised. And with the support of colleagues and the heads of midwifery, we made our dream come true. So by transforming our session into a digitalised resource, we've improved access to all families, helping remove barriers. The videos enable flexible viewing beyond the wards, enabling families to revisit and choose the information that they need. And it also ensures consistent evidence-based breastfeeding information, which we see there's a lot of the other out there. Just have a look. And then just touching on future projects. So now we've started, I feel like there's no stopping us. We're so passionate. In sort of the dream would be to digitalise all information, create a video library that's accessible to everybody. It makes it really easy for everybody in maternity to be able to share these QR codes and these videos. I've just touched on some ideas that I've had, talking about paced responsive bottle feeding and related techniques. We've got transitional care on our ward, so supporting premature babies and reluctant feeders. It's really important to get that information across to families. I'd like more videos about finger feeding using supplemental feeding systems. Really important. We see a lot of engorgement, mastitis. Want the guidelines and the current guidelines to be accessible to all, and the prevention and the treatment. And as I said, we've got the flange fitting expert with us. So breast pump guidance, including how to correctly size your flange. Really, really important. We don't talk about maximising milk supply in those early days. We want newer videos that we can put out there using hands-on pumping techniques. And like I say, I've got lots and lots more ideas. And then, yeah, that's literally it from me. I didn't want to talk for too long and bore you all to death, but questions and answers, and thank you so much for listening. I'm sorry you can't see my face. I've got a massive smile. I'm really happy to be here. Thank you so much.
Oh, Thank you so much, Jasmine. What a fantastic presentation. And I know that you're so passionate about the work that you're doing there. I'm going to open the floor up for any questions or comments, please. Rula, hello. Do you come in?
Hi, Rula.
Hi, very, very interesting. I would like to know, how does the breastfeeding support on the phone works?
Yeah.
Do the ladies have the number or the families before they leave the unit? Is this support given whilst they are in the unit or when they go home?
So as maternity support workers, we are the sort of the worker ants on the ward. We are the feet on the ward, up and down the wards, giving one-to-one support. We're also supporting all our colleagues on the wards with giving support. If anyone needs to ask anything, if anyone, isn't sure, they know that they can come to us and we're a safe space. Once the ladies come along to the class, hopefully the patients that come along to our class then are shown the wealth of support in Oxfordshire and our surrounding area. The infant feeding team have created a Monday to Friday calendar. I'm sorry, I didn't even think to show that, but maybe we could share.
I do have it if you want me to share.
Yeah. We've shared a calendar, and it's Monday to Friday of all the breastfeeding groups in the community. And then also we've selected QR codes of really, really great videos that are out there, obviously evidence-based breastfeeding support and guidance, and we've popped those QR codes onto that information so that, there we go, fantastic, so that patients can access that information. So you've got us at the infant feeding team, you've got all our staff on the wards are trained by us, and then we've got lots of information to give them. Then when the patients leave us, there's also our phone number and our email address, that if they need ongoing support and they're not able to access the support in the community, our midwives are sat on those phones day in, day out, supporting over the phone as well. And I understand where you're coming from. It's difficult, I suppose, to give sort of one-to-one support over the phone, but the midwives are so, they've been doing it for so many years, they can do it with their eyes closed, and they know the exact questions to ask and the where to direct people for support.
Thank you.
Thank you so much. Great question. There's a question in the chat for you, Jasmine, and actually it was my question as well. The digital resource sounds fantastic. And does that come in any additional languages, translated or in an easy read version?
Definitely something we want to, we all know this, that we're all using. I don't know if you guys use Language Line, waiting on the phone to speak to someone at Language Line, and we're using all the resources on the internet. We would definitely like to make a language based library and cover all languages. There's lots of languages there that go on, Amber.
I think because it is uploaded to YouTube, it does have that automatic translation on YouTube. So I think it's built within, and it's on a platform that allows that translation of languages. But correct me if I'm wrong.
Thank you. Are you able to share the link at all to your YouTube videos, please? That would be fantastic. And there's lots of love in the chat for your calendars. And Angela's said that they use a Padlet as well for infant feeding information, so similar platform as well. Yeah, do have a look at the chat. Lots of love for you guys in there. Any other questions or comments for Jasmine and Amber? Okay.
I have one more again, sorry. Is your unit covered every day by a breastfeeding team? One of you, basically.
Yes, I am in charge. I'm the infant feeding lead, and I am in charge of rostering. And so I try to ensure that every single day has at least one person on, and preferably 2 to 3, depending. But we also run a complex feeding support clinic by a lactation consultant, midwife, nurse, and that is separate to our ward support. So that's where we bring people in from community who are struggling once they've been discharged. So it looks a little bit different in the day-to-day, but we hope to have at least 2, if not sometimes 3 staff on any given day.
That's very good. Thank you.
Thank you. And there's another question in the chat around kind of the staffing of your team, and if you can recap on how many members there are and what roles they are.
Yeah, so I keep in mind our birth rate is large. We have over between 5,500 and 6,500 births a year. So at the moment we have myself, which is full-time band 7 infant feeding lead. We have a 2 whole-time equivalent band 6 infant feeding specialist midwives, and we have 3 whole-time equivalent infant feeding specialists MSWs.
Thank you. Lauren.
Hello. So I don't know if you, first of all, we'll just use the question in the chat, which you've just done. So thank you. And I also just wanted to ask, so sometimes the feedback we get, obviously in postnatal wards are really busy environments and high turnover of women, and lots of staff with different roles now, more and more so, sort of divided up roles. And that can be challenging for the women as well to understand who's responsible for what part of their care. And so it was just a question to you both, really, Amber and Jasmine, like, how do you manage that when women sometimes they want to ask you about their pain relief, their bleeding, their all these things at the same time as getting their infant feeding support, and how do you make it work well with the wider team on the ward?
Yeah, so there's a few things. One is that we have our own special lanyards for our infant feeding team. So we have a special lanyard that says infant feeding team, and it's a different color than what you might normally see. And obviously, if someone says, I need support, I mean, I'm not their midwife, I'm not caring for them as their midwife. So even if they ask me for medication, I say, let me grab your midwife, or can you ring the buzzer and ask your midwife? And so really it's just knowing your scope, knowing where you need to refer. But we've also built an inpatient referral system within BadgerNet so that we can have those midwives or support workers or the pediatrician, the peds, send referrals for complex feeding support or excess weight loss or anything like that on BadgerNet. So that way that we have, in-person handover and referral, but also on BadgerNet as well. But it's mostly just saying, hey, let me grab your midwife for that pain medication, and just liaising together like that.
Great, thank you. Do you do joint handovers face to face then as well? Is that what you alluded to? So yeah.
Yeah, we do. It's definitely something we're still working on, but there is a handover in place in the mornings that we try to join and make sure that those patients that are needing really complex feeding support are being highlighted to us.
Great. Oh, that's a really good example. Thank you.
That's right.
Thank you so much, both Jasmine and Amber, for coming to talk to us about your early days project, and wish you the very best of luck with all of your next steps, and do keep us updated. It'd be great to see how you get on with all of those things that you would like to do going forward. So thank you
so much. Thanks, everybody.
You're very welcome.
Thank you.
Do stay on, and I hope you enjoy the rest of the webinar. Okay. So next up is Angela Nash. She's the lead PMA at Hampshire Hospitals, and she's going to talk to us about implementing a specialist midwife daytime on-call system. Over to you, Angela.
Thank you. Just see if there we go, on my sides. Just doing weird things. My Teams has been playing up today, so okay. Can you see that?
Yes, it's coming up now. Yes, perfect.
Yeah, you can just see the slides, yeah?
Yes, that's right, yeah.
Okay, yeah, that's right. So I'm Angela, as Charlotte said. Thank you for the introduction. I am the lead PMA at Hampshire Hospitals. So just as a bit of background, we have got 2 acute sites, so one at Winchester and one at Basingstoke, and we also have a standalone birth centre in Andover. So we're quite a large sort of trust, and we do have quite a lot of specialist midwives. I think we had around 26 when I first brought this project in. So as a bit of background, so the aim was to introduce a structured daytime on-call system or a helping hands rota for specialist midwives. And the purpose of that really was to improve equity, reduce anxiety amongst the specialists about working clinically, support the clinical teams in times of escalation, and reduce site diverts also. So in terms of local drivers, so we had a new director of midwifery in post around 2 years ago now, and she initiated a workforce review. So part of that was looking at what we did in times of escalation in terms of staffing. So in terms of the escalation policy, it was found that it really lacked clarity and consistency in application. So sometimes the matrons were asking the specialist to work clinically, sometimes it was the band 7s, sometimes the unit wasn't always an escalation, sometimes it was an escalation, but it wasn't always being declared. So we need more clarity around that. We got a lot of feedback from the specialists about frustration and anxiety. So anxiety about working clinically, lack of equity. So it was very much the same people, the same specialists were always getting asked to work clinically. And obviously that had a huge impact on their specialist workload. And then obviously that need to maintain clinical skill and also team integration as well. So the sort of clinical teams getting to know or being aware of the specialist midwives and their roles, etc. And also it's, you know, that skill fade was quite apparent with a lot of the specialists because they hadn't necessarily been asked to work clinically. And obviously if the times that they were, it was very busy and it caused a lot of anxiety. So this was the methodology that I used. So I did PDSA cycle, stakeholder analysis, SWOT analysis, and I also used the DMAIC framework, which is part of Six Sigma. So in terms of implementing this, so to begin with, I surveyed all the specialist midwives to assess their confidence of working clinically, their anxiety levels of working clinically, what upskilling needs they had, and their experience of being asked to work clinically as well. I also surveyed the shift leaders to assess what their current practice was when they were asking specialists to work clinically. So whether they did that themselves, whether they declared it to the matron, and she would ask those sorts of things. So we did our best as well to facilitate any upskilling that the specialists felt that they needed. And we were then using a Microsoft form and also using Inphase to track and report when the specialists were required to work clinically. So initially I developed an Excel-based rota, which was accessible to senior staff, so the band 7s and the matrons. I also created a Teams channel where all this information was centrally stored. And then I had lots of communication and meetings with the matrons and the band 7s about how we were going to improve that process, what it looked like, etc., and answering any questions that they had. So these are my calculations, how I worked out how many on-calls each specialist would need to do. So it was just basically working out the total available hours, taking minusing 15% of that to account for annual leave, working out our whole time equivalents, determining how much coverage we needed, and then converting that into hours. So it worked out that if you worked 7.5 hours, it was 1 on-call per 8-week period. 10 to 19 hours, 2 on-calls, etc. So anybody working full-time was required to do 4 on-calls per 8-week period. So obviously there have been challenges. It's definitely been a process and it still remains a process. So at first, obviously, it took a while to embed into practice the actual using of the rota and also making sure that escalation was being declared, that the matron was asking the specialist midwives or whoever was in charge that day for making sure that we had enough staff. So that did involve a lot of regular communication with the matrons and the band 7s. So we did find that actually our busier months, which were our summer months of July to January, sort of this latter part of the year, we didn't have enough cover. So our director asked me to increase the requirement. So we had 2 specialists on call. So we've got 1 first, 1 second. So basically it's doubled the amount of on-calls that people have to do. So for example, a full-time specialist would need to do 4 first on-calls, 4 second on-calls. Obviously you've got less likelihood of being called if you're a second, but there is that backup if we did need it and we need more staff. So we did find that maybe initially it was a slightly overly complicated and time consuming. So I simplified the rota into a Word document rather than an Excel document. Initially I did it by months, but then I found very quickly that was just confusing for everybody. So we then condensed it into 1 8-week period for each rota. We also abandoned the MS form for reporting, and we've just now used InPhase. So I did have a lot of challenges with the specialists not putting their on-calls in. Obviously, most of the specialists are band 7s. They are, responsible for their own workloads, etc. And part of me doing this as well as another specialist was to make sure it wasn't anything punitive. You weren't asked to be on call because you've done something wrong, or it's not supposed to be a negative thing. This is supposed to be actually, let's help out the unit when we're in escalation. Let's make sure this is fair for everybody. So people are taking that responsibility did take a little bit of encouragement. I did have to introduce deadlines and reminders, which is fine because we're all busy people, right, at the end of the day. But they do know that if they don't complete on calls, then they will be rostered by a matron. We've not had to do that yet, thankfully. But there just needed to be a process of, this is when it needs to be done by. This is, the process that we have to follow if they don't get done. So we did have an issue. We still maybe do to a certain extent that we don't have Fridays covered. So we put in a requirement that we had to work 1 Friday per 8-week period if that specialist worked Fridays. Another challenge was that we have got a certain number of midwives who only work on postnatal due to health work agreements, etc. So there was an agreement that we could have an extra person on call that day. So if we've got 1 person, if they're the first on call for postnatal, then we'll have another person, if there's enough people, obviously, to then be called to work on the labour ward. So last year we had a bit of an issue with the lack of cover at the end of the day, because obviously a lot of the specialist midwives don't necessarily work long days. They tend to finish at sort of 3, 4, 5 p.m. And also an issue with, if the unit's really busy and we're being asked to work clinically because we're short staffed, which is not so much of an issue anymore. But in those circumstances, obviously there's not always somebody to take over from that specialist. So we had a little bit of an issue with people not being released on time. So that is still a work in progress at the moment. It's not been much of an issue recently, but I predict that actually in the summer that might come up again. So that is a work in progress still, and that's looking at that allocation. So just as a recap, so we have an 8-week roster on Word, and that's accessible to the matrons and the shift leaders via the Teams channel, obviously to the specialists themselves so they can input their own calls. The midwife specialist is responsible for completing by the deadline, and I do send the reminders, and they're also responsible for swaps. So very happy for people to swap. They need to try and do it between them if they can, which they generally tend to do, and if they have trouble with it, then they'll come to me, which is fine. And then mostly people are now also submitting their InPhase when they've worked clinically, and also highlighting it on the roster. And that really is to, obviously it's one of our maternity red flags, specialists been used clinically, but also it makes auditing easier to actually look at, is this actually fair? Are we still putting the same people, etc. So when I last sort of looked at the impact of this, when I first looked at it, it definitely was improving equity and transparency. We found that there was reduced anxiety of the specialists and reduced impact on their workload. It's led to better MDT working because the wider team are more aware of the specialists and being around, and obviously there's that clinical, what's the word? No, my brain's gone. That confidence that the specialists are still able to work clinically. I've forgotten the word for it, sorry, perimenopausal brain. The clinical service has been better supported, and that's definitely had a positive impact on patient care, and the diverts have been significantly reduced between our sites. Obviously, challenges, I've already mentioned a few, that variation in daily need. So sometimes we do still need to ask other specialists to work clinically who aren't on the roster, but that's a lot less than it used to be. The impact on specialist workload, obviously it is quite a big ask to expect people to do this as well, so it does still have an impact, but again, much less so than it used to for certain specialists anyway. Obviously for the specialists who never used to work clinically, it has had more of an impact on them, I feel, but it does mean that it is fairer across the board. So oversight of the roster and that accountability, so that has fallen to me, which is fine. I've, you know, it's been a learning curve for me about how to manage that, about boundaries to put in place, etc. And managing expectations, and that really is about ensuring that the specialists have been aware that this is their responsibility. If it doesn't get done, then somebody does have to do it for them. Making sure that they are on the right site at the right time, etc. And also knowing that just because we have somebody on call, it doesn't mean that we are not going to get asked to work clinically, because sometimes there is that need due to acuity, due to staffing, etc. We have had to do a bit of work on de-escalation. So, it might come to a certain point in the day where actually we're not needed anymore. And we have found that to begin with, the band 7s weren't always necessarily sort of taking that de-escalation, but that has definitely improved. It still sometimes is an issue, but again, it's just a work in progress. And then in-phase reporting, initially, that was a challenge. People weren't necessarily reporting, but again, that has got better. So I did a recent evaluation. I got probably about 50% response rate from the band 7s and the matrons, and also from the specialist midwives themselves. So from the sort of senior team, sort of the band 7 matrons, so they felt that the roster was well designed, it was well understood. Clinically, they really saw the value in it, and it was widely appreciated, and there has been that significant reduction in cross-site diverts. From the specialists, they have reported back that self-rostering gives predictability and some control, and there is generally that goodwill and the commitment to supporting safe patient care. They understand the reason for it, even though it does sometimes have an impact on their workload. It has helped maintain basic clinical confidence and reduce anxiety whilst working clinically. And they are very happy with the way the roster has been coordinated and communication as well around it. So in terms of challenges, so from the band 7 and matrons perspective, availability of the person on call or on-site presence has sometimes been an issue. So I've had specialists forget they've been on call. I've had them have to change site at last minute, etc. So they're not always available. And also that adequacy of cover during peak demand. Sometimes even 2 people isn't enough. So, and that's always going to be an issue, but it is quite rare that that's an issue. So in terms of the specialists, they have found that their work can be spaced, and a small number of them are having to complete work outside of their hours. But this is by far not the majority. So that obviously it has increased some pressure for some of the specialists, and especially those who don't usually get asked to work clinically. And there is still a little bit of perceived inequity in who gets called to work clinically due to clinical skills. So sometimes if the first person has been called that's on the roster, they will still cherry pick the people they ask because they know they are very clinically confident and capable. So looking at it, we have had a loss of some specialist roles. We've either abolished the roles or people have moved on. So we don't have as many specialists to cover. So we are looking at the moment of possibly reducing it to a 7-week roster. Not sure how well that's going to go down, but we will see. We have to adapt with the times. So So in terms of leadership and culture, so in terms of implementing this project, it was really important that we had that compassionate and visible leadership, and that we were shifting from a reactive to proactive staffing support. And we really tried to lead collaboratively with stakeholders, which has reinforced the value of the PMA role in QI initiatives. So next steps, and this is ongoing, continue to monitor regularly our in phase and regularly audit, and also evaluate effectiveness and staff feedback, which again I have done recently. So really, this QI project demonstrates how structured systems and inclusive leadership can improve staff wellbeing, equity and patient care, and that ongoing review and adaptation will hopefully ensure sustainability. So I think on reflection, this really could be considered a bit of a cross between a QI and a transformation, because although I knew what needed to be done, so from a transformation perspective, I knew what needed to be done, I didn't know exactly how it would look. So it's been very much one of those projects that I've had to regularly revisit and revise, which is obviously where the QI element comes into it. And that is me done.
Fantastic. Thank you so much, Angela. That's a great presentation. And you have got hands up already, so I think this is going to generate lots of discussion. So over to you, Rula. Do you come in?
Thank you. Angela, obviously sounds that is working very well. What is the biggest problem now? It sounds as though what's left now, really, the problem is shortage of staff. Would you agree?
Yes, so we have been in a really good position at Hampshire Hospitals. The last sort of year, 18 months, we have been fully staffed. We have had quite a lot of people recently go on maternity leave, get different roles, etc. So we're not quite where we were, say, 12 months ago. But that's always going to be an issue. And I think hopefully we're going to build up our specialist pool again, so hopefully we will be able to go back to that or continue that 8-week roster, and not put any more pressure on the specialists, because I am really aware that this does put a lot of pressure on people, but equally, as I've said, it also relieves a lot of pressure on people as well, because we have people who never used to get asked to work clinically. You know, it's spread out better now, and it is generally the people that never used to get asked that view it more negatively, whereas everybody else is quite positive about it. So does that answer your question?
It's a bit, yes, thank you. It's a bit like our community midwives. They're very good, but they're a little bit reluctant when they're asked to come in as an on-call, because obviously they are not clinically the same as somebody who works at the unit. So we understand that, and we try to support them and help them.
Yeah. Which is tricky when people don't feel confident working in that area. So what we've done at Hampshire Hospitals recently is last year we've switched. So all the so our on-call overnight, our community midwives no longer have to come into the unit. They're now on call for home birth and community birth, with a home birth midwife as the first on call. So that's, although there has been a lot of pushback because the community midwives haven't done community birth for a long time, it's still a more comfortable area for them to work in rather than the unit, which is obviously generally very high risk, and they have completely de-skilled in that area. So
because people have to be happy, otherwise they don't work the same.
Exactly 100%.
Yeah, thank you.
Thank you. Margaret, do come in.
Thank you. Can you hear me okay? Yeah. I'm in a busy office today, so there'll be background noise. Thanks, Angela, for your openness in sharing that, really. And I suspect there's been progress because it's been led by clinicians, co-designed with clinicians, hasn't it? Yeah. And it provides opportunity, doesn't it, for everybody to understand challenges and the pull to areas of high acuity. And sometimes that doesn't go two ways, which you clarified around. You know, the pull is always one way, but there are people that don't have the same reciprocation back. So I just wondered, when you're thinking about impasse and the evaluation, have you seen any impact to the care provided to women when specialist midwives may have to divert what they're doing in their role? Just curious.
So, as in impact in a what impact particularly are you talking about? An impact that could be perceived as not necessarily overly positive because the specialist doesn't always work clinically, or
no, I was thinking more if they're called during an on-call shift, or whether it's during their working day and they've got things to do that are really important to a woman or a person's journey. How do you evaluate that?
I mean, that I have asked very specific,
because that's still a red flag, isn't it?
Yeah, absolutely. I have asked very specifically within the evaluation what impact it's having on their specialist workload, but I think the overall point of it was that actually they were in charge, they were in control of when they did their on call. So generally people don't book in, they don't book in meetings, they don't have clinics. We have a lot of specialist midwives who don't necessarily have a clinical aspect of their role, so they will obviously make sure that they haven't necessarily booked in lots of meetings, etc. The midwives who do have a clinical aspect to their role, they will very much try to avoid using those days where they have got, they've got clinics, etc. They won't book an on-call for that day. So actually, in terms of the impact on their already clinical work, it's improved because they don't get just pulled at any old moment generally and have to cancel whatever they have been doing. So yeah, I think it's definitely it's definitely positive from that perspective, but it's you have to think about actually how is this going to work in practice, how can we minimize that impact on our service users, because it is supposed to be of benefit to our service users. So so that's how we've sort of managed that. I don't know if that answers your question.
I think it probably does. It's given ownership to people.
Exactly.
Yeah, great. Thank you.
Thank you.
Thank you, Margaret. Susan, do come in.
Hi, thank you, Angela. That was really helpful. This is something that we've done in the past. In fact, I think probably it was COVID that sort of prompted us to, it was really all hands to the deck then, wasn't it? And I think there was a lot of positivity about it at the time, again, but partly to make sure that there was equity across all the specialist roles. Gradually, it's faded away, and we've just recently tried to sort of reinvigorate it and think again. And what we found, and I wonder if it was your experience, we've got an awful lot of our specialist midwives have perhaps moved into a non-clinical role because of health issues. So and we found we had quite a large proportion who wouldn't be able to work clinically. That's why they've come away from the shop floor, as it were, which then again felt inequitable to make those who are fit and well to do something. We're not asking people who can't do it. So I just wondered whether you had any experience of that, and if so, how you overcome it. And just a second point, I just wondered what you did about you talked about having upskilling, sort of upskilling those who weren't confident. I wonder how you address that. So thank you.
So the upskilling, they spent time with our clinical educator, and clinical education also Badgernet. It's mostly in terms of skill, it's not necessarily always the clinical skill that's been the issue. It's been the use of Badgernet, because we only brought it in 3 years ago. So people weren't confident, say, for labour care. So they spent time with the digital midwife, spent time with the clinical educator, and also I think, looking at the bigger picture, I think we are now moving towards all of our new specialists, and actually I think there's probably plans to make us all do this, have a requirement within their contract to work 1 clinical shift a month anyway, so to try and prevent that skill fade. So we have in the past had people who can't work clinically, but it's not really a thing anymore. We've very much we are midwives. We need to be able to provide midwifery care. So we've had a lot of redeployment, etc. And we, as I've mentioned, we do have some midwives who have health work agreements about only working on the postnatal ward. But the way that we've kind of managed that is we only have a few of them. The way that we've kind of managed that is making sure that they can double up with somebody, so that actually if it's postnatal that's need, they will go there, but if it's stable, then there's somebody else to take that on. But I don't know how you necessarily would manage the fact that you have got quite a lot of midwives who can't necessarily work clinically. It's a bigger issue. Yeah,
it's not easy to solve, which is why we're struggling.
No, of
thank
course.
you. Just going back to the people who only work on the postnatal ward, so would there be a scenario where a specialist would go to the postnatal ward and then you'd ask somebody from the postnatal ward to go to labour ward instead? Because again, we've had that scenario, and that's then not very popular with the staff who are being asked to move for the sake of the specialist. So again, it's about those sort of relationships.
Potentially that's always the risk, but obviously in terms of the hours that the specialists work, they're not there for the whole 12.5 hours. So actually there's postnatal needs to be staffed anyway. I think generally if that's an issue, they will tend to ask somebody else who might not be on the roster to maybe go to labour ward. But yes, I understand that, because it could definitely potentially be an issue when the staff are asked to move elsewhere. But generally they're just going in to help cover breaks, those sorts of things. So yeah.
Thanks. Thank you. Great question. Lauren, do come in.
Thank you, and that was really great presentation, and it's really well done, and I think a lot of people will be listening to this and thinking about what they can take back to their units. Also, thank you, Susan, for your really great questions, because you covered quite a few of mine already. So I was thinking from a practical perspective a little bit about the competence self-assessments that you did for the specialist midwives, and might be something to think about for next steps, just having that sort of annual self-assessment. And it's usually, as you say, we're not trying to sort of avoid the language of upskilling, because these are skilled registered midwifery professionals.
Yes, of course. Yeah.
It's more about that reorientation, isn't it, around digital tools and things like that. So it might be quite a useful thing to think about, like an annual self-assessment around what's new, what's changed, and it just helps then from a specialist midwife perspective to take that onus and get that back in place. So it's good to hear about what you've done to support them. I also wanted to ask about what happens after 5 o'clock, which you started to touch on. So that's often a challenge, isn't it? So and we all know, particularly around our triages, for example, those real surge periods often drag post 5 p.m. So how do you manage that? And how you said that some midwives have had to do extra hours. Is that how you're managing it?
So it's not been an issue very often. I think we've had periods of maybe when we've had higher sickness and higher acuity, sort of last year, that it was an issue. But again, it's not something that happens regularly. And generally, the specialists will be asked, are you okay to stay later? And if they say no, they say no. That's that. They have to do that. But generally, obviously NHS runs on goodwill, doesn't it? So we'll often stay. But as I said,
it's not a requirement as such.
It's not a requirement, but also none of us are going to say, to women and labour, sorry, I'm off now. There's nobody to look after you. We're not going to do that. And I think senior management have been really good in going, well, we can pay you bank hours for those hours that you've worked over, or you can take that time back, etc. So there is that flexibility. It's about working together as a team, isn't it? That's the whole point. So
but also that feeling of safety, like the whole idea of the project is to make sure people felt safe, and that can be a challenge if you sort of contracted hours. And so that's really good that you've got that flexibility for people. And sorry, I've just got two more.
Okay.
And I'm just mindful. Just one more question. The other thing was that you said it's not in your escalation policy yet. So is this going to go into your formal escalation policy?
It is.
Yeah.
Maybe the minutiae of it isn't in the escalation policy, but yes, we will be. I think we'll be adding to it.
And then just wondered how we've used this information to sort of look at general unit staffing. So you were clear that you've had to double up on your on-calls during the winter period, and if it's impacting certain areas, and whether it's been really useful for your head of midwifery or director of midwifery in supporting them in looking at workforce needs generally. Has that?
Yeah, I think it has. We, as I said, we have been at full establishment for quite a while now. We've been in a really, really lucky position. So even though we have had to put in that requirement it's usually not because we're short-staffed. It's being used because actually the acuity is really high. But a lot of work has gone into workforce at Hampshire Hospitals. And I think it probably has been. I don't know for definite. I can't say that hand on heart with any certainty, but I think it definitely has helped identify when our busier periods are. And also part of that has been revising the annual leave allocations, etc. during that time. So there's been a bit of a shake up in terms of that. So yeah, I think that's a good point, that actually it probably has helped in terms of general workforce.
Yeah, it's just showing those peaks and troughs.
Yeah.
Really great project. Thank you.
Thank you.
Thanks, Lauren. And Sasha.
Thank you. Thanks, Angela. It's a really interesting presentation. I think most of us that have been through senior midwife or band 7 positions have lived and breathed this ourselves in trust. So you can resonate with it very easily. Just a couple of two things. The first one was around the kind of the anxiety around being pulled to work clinically when you've not done that, and how that exposure can be gained without it feeling so, and without being too like resource heavy on other colleagues having to provide that kind of buddy system to bring people up to de-skilling. I just think something that my time as a bleep holder I used to do, and if I was to be pulled to work clinically in an area that I hadn't worked in for a while, for example, would be around covering lunch breaks.
Yes.
And just popping in for like 30 minutes or an hour, like in busy maternity triage, for example. If you've not done that for 5-10 years, can feel massively scary. But you've often got other people around, and also it's a lot less anxiety inducing just to do that for 30 minutes. And then you've kind of had that, and then you've been there, and sometimes it is just the thought of going there, but to be called there for 8 hours versus an hour is quite different. So just wanted to I'm sure you've thought of that already, but just to maybe, even on a day that they're not on call, just buddying up and saying, can you cover a lunch break
absolutely
on labour
and I think
ward?
So that was a bit of an issue to begin with, that people resented being asked to cover lunch breaks, but actually we've kind of gradually been able to work on that exact thing, that actually this is good. You are just you're only going to be there for an hour. And what was I going to say? Sorry. My brain's gone again. Yeah, so now even if the unit isn't in escalation, they do know that if you're first on call, that there is a good chance that you'll be asked to cover breaks. But there's definitely a lot less resentment around that now, because I think people can see the benefit of it. But you're right, that is a very good way to get people sort of back into that flow. So,
and once it's something that's just normal, it becomes less of a
exactly
big thing.
And part of that is obviously that backing. It's not all on me. That backing from the senior team to go, look, we really want to make sure that everybody, all the clinical staff, have their lunch breaks, because this is really important. You're working a 12.5-hour shift, you really need to have a break. So even if we're not in escalation as such, making sure that they are doing that, and with our help, then that has been that's been really beneficial.
Thank you. And then just the second thing, when you spoke about that kind of bit between 4 and 8 or 5 and 8, or that latter part of the shift that's sometimes encroaching on people's home time, just a a colleague of mine used to do she was a lead midwife for the postnatal ward, so had a slightly unofficial clinical aspect to her role, but was supposed to be office based. She used to do like an 11 till 7 or a 12 till 8, which suited her quite nicely. It was still like an unavailability on health roster, so it didn't give any enhancements as an office kind of role, but it just meant that her area was supported between those hours as well. It was just a bit more of a buffer, and it really suited her life. So just another kind of practical idea, really, just because sometimes that being offered, you want to do your food shop or go to Pilates in the morning, that's taken away from people that work 9 to 5 days a week sometimes. So but really interesting. Thank you for sharing that.
Thank you for your ideas, everybody. That's been really helpful, actually. It's taken some good things from it.
Fantastic. Thanks so much, Angela, for sharing that. And I know you have presented this at one of my previous events as well. So I think your QI project's already registered on our QI project register, and your slides are up on the Futures platform. So I know you've updated your slides, so I might swap them out. So brilliant project. Thank you so much, and do keep us updated with what happens next. Thank you. Okay, so we're going to move on to, we've got one more question. But did you put your hand up, or was that? No, she's doing hearts for you. Okay, fantastic. We're going to move on to our final presentation, and this is a video recording from Rosie Butler, who's the Pelvic Health Service Physiotherapy Lead. So I'm going to share my screen and include the sound and hope that this plays. So once playing, can you see that?
Yeah.
Yep. Okay, so I'll press play and give me a thumbs up if you can hear. Thank you.
Thank you for inviting me to present this morning, and my apologies that I'm unable to attend in person. For those of you who don't know me, my name is Rosie Butler. I'm a pelvic health physiotherapist currently on secondment to the Hampshire and Isle of Wight local maternity and neonatal system as the physiotherapy lead for the Perinatal Pelvic Health Service. The aim of today's presentation is to share our learning from the development and implementation of a digital physiotherapy self-referral form for the Hampshire and Isle of Wight Perinatal Pelvic Health Service. I'll focus on what we set out to achieve, the challenges we encountered, and some of the key insights that may be useful for others considering similar digital or pathway developments. Perinatal pelvic health services were established by NHS England to improve the prevention, early identification and treatment of perinatal pelvic health conditions. These conditions are common, they are impactful, and we know that early access to the right input can make a real difference to long-term outcomes. However, when we reviewed provision across Hampshire and the Isle of Wight, it became clear that the reality did not reflect this ambition. Findings from our baseline service user survey demonstrated significant inequality in the access to pelvic health physiotherapy, with marked variations across the system. Referral routes were multiple, complex, and inconsistent between localities. In addition, there was only a single self-referral pathway available across the system. This relied on a telephone-based process that required service users to call during office hours, with no guarantees of being able to speak to someone. This created a clear barrier to access and disproportionately disadvantaged those unable to engage with the service in this way. In practical terms, this meant many women and birthing people reported experiencing long delays in accessing specialist physiotherapy in Hampshire and the Isle of Wight. Some didn't access care at all, and others felt they had no option but to seek private treatment. This clearly isn't aligned with the principles of PPHS or the wider goals around equity and access. It highlights a clear need across Hampshire and Isle of Wight. Access needed to be simpler, clearer, and more consistent, both for women and birthing people, but also for clinicians trying to refer into the service. And this gap is what led us to start thinking differently about how we approached access and referrals. In developing the self-referral form, we referred directly back to the Perinatal Pelvic Health Service specification. The specification mandates equitable access to perinatal pelvic health service across the entire local maternity and neonatal system, regardless of where women or birthing people live or which provider they access. To deliver this in practice, access routes must be clear, simple, and consistent across the system, reducing confusion for both service users and professionals. Supporting self-referral is a key component of this approach. It enables early access to care and helps address the well-recognised underreporting of pelvic health symptoms. Where appropriate, single point of access models are supported by the specification, as they simplify pathways, improve equity, and ensure women are directed to the right service at the right time. Overall, this approach aligns strongly with the NHS long-term plan priorities, particularly prevention, early intervention, and reducing health inequalities. The development of the self-referral pathway was underpinned by extensive stakeholder engagement across maternity, gynecology, physiotherapy, service managers, commissioners, primary care, health visiting, maternity and neonatal voice partners, and digital teams. We started with baseline workforce and service user surveys to understand current provision capacity and lived experience of accessing pelvic health services. We then mapped existing referral pathways across Hampshire and the Isle of Wight, which allowed us to clearly identify areas of duplication, delay, and inconsistency within the system. Using this information, we worked collaboratively to agree clear referral criteria, including exclusions and triage priorities, ensuring referrals are managed safely, consistently, and equitably. This structured approach has supported the development of a simplified, system-wide pathway that improves access while making best use of the available workforce capacity. Working with our multidisciplinary stakeholder group, we developed a digital questionnaire to capture pelvic health symptoms and risk factors. This was informed by the International Consultation on Incontinence Perinatal Pelvic Health Self-Assessment Questionnaire, alongside a review of existing approaches used nationally by other perinatal pelvic health services and established musculoskeletal physiotherapy self-referral models. As a group of clinicians, we recognised that despite variations in services, we were all using a shared set of informal but consistent clinical decision-making rules to determine whether a woman or birthing person was suitable for group education as a first-line intervention or whether they required a face-to-face specialist assessment. We worked together to formalise this collective clinical reasoning into standardised triage rules, which then formed the basis of a rules-based automated triage process. In parallel, we developed screening questionnaires to ensure that referrals were appropriate for physiotherapy and to identify symptoms that would require escalation, medical review, or alternative clinical input. This included the integration of red flag screenings for cauda equina syndrome. Following a scoping review and options appraisal, a paper was presented to our executive board. A decision was then made to use the Healthier Together platform and to work in partnership with the Healthier Together team to support the development of our digital self-referral form. Healthier Together is a platform that service users across Hampshire and the Isle of Wight are already routinely signposted for trusted information and advice during pregnancy and for child health advice up to the age of 18. It is well recognised locally and already embedded within existing pathways. Once we began working closely with Healthier Together, we were able to see our vision start to become a reality. The following slides show the screening questions that sit right at the front of the self-referral form, ensuring safety is embedded from the very start of the pathway. The first screen focuses on cauda equina syndrome, using the nationally agreed screening questions. These are standardised questions taken from the National Suspected Cauda Equina Pathway and the MACP Cauda Equina information resources. If a service user answers yes to any of these questions, they are immediately presented with a safety pop-up. At this point, they are unable to continue with the self-referral form and are advised to seek urgent medical advice. This ensures that anyone with potential red flag symptoms is appropriately signposted to urgent care. At the very beginning of the self-referral form, service users are first asked whether they are currently pregnant or postnatal. This allows the pathway to tailor screening questions appropriately from the outset. All users then complete the Cauda Equina screening questions. If these are answered negatively and the service user has indicated that they are pregnant, they are taken to a set of pregnancy-specific screening questions, as shown on this slide. These questions are designed to identify and exclude important obstetric red flag conditions. If any of these symptoms are identified, the service user is appropriately advised to seek urgent maternity or medical review, ensuring safety is prioritized before progressing through the physiotherapy pelvic health pathway. This stepwise approach ensures that pregnant women are screened safely and consistently with clear signposting to the right care at the right time. Following pregnancy or postnatal identification, and after completing the Cauda Equina and pregnancy-specific screening where relevant, service users then complete this final safety screen. This section asks about experience within the last 6 weeks and is designed to identify conditions that are not appropriate for management within the pelvic health physiotherapy pathway. This slide outlines the pelvic health physiotherapy service triage outcomes using a clear 3-tiered model to ensure women and birthing people are directed to the right level of support. At Tier 1, shown in green, women and birthing people receive universal information and advice focused on pelvic health. This includes prevention, early identification of symptoms, and access to high-quality digital resources, such as the POGP videos and the Squeezy app. Women and birthing people are signposted to the Healthier Together pelvic health advice pages, with assurance information shared with providers. Women and birthing people who complete the self-referral form and are automated to a green tier 1 outcome have no symptoms or risk factors for pelvic health. Tier 2, shown in amber, supports women who are symptomatic but not experiencing severe symptoms. This includes those with antenatal or postnatal risk factors, excluding OAC. Women are offered an online class intervention facilitated by midwives and physiotherapists. They are advised to self-refer again if symptoms persist, and providers receive assurance that triage has taken place. At Tier 3, shown in red, women and birthing people with moderate to severe symptoms, including those with OAC or ongoing symptoms despite Tier 2 intervention, are referred directly for one-to-one treatment with a perinatal pelvic health physiotherapist. Healthier Together generates an email referral to the provider to action an appointment, and women are also given contact details for the clinical team. This tiered approach supports safe triage, early intervention, and equitable access across the system, while ensuring specialist capacity is prioritised for those with the greatest need. For service users who receive an amber outcome on completion of the self-referral form, they are directed to book an online pelvic health class. Based on their responses, the system recommends a structured group intervention delivered by the physiotherapy and midwifery teams. Users can choose a convenient date and time or access a pre-recorded session if they are unable to attend live. This ensures timely support, early intervention, and clear next steps while allowing users to re-refer if symptoms persist. To support accessibility, The pelvic health advice and self-referral pages can be translated into a range of languages using the website's translation function. It is important to note that this translation is generated using AI technology, and while it aims to improve accessibility, it may not be as accurate as human translations. At the top of the page, there is also a share button. This function allows healthcare professionals to easily share these resources with women and birthing people. The link can be shared directly via text message, or a QR code generated to share. You can copy the link and share it in an email. You can print the pages, or you can share via social media platforms. One of the key challenges in developing the self-referral form for Hampshire and the Isle of Wight Perinatal Pelvic Health Service has been maintaining consistent engagement with a wide range of stakeholders. While the PPHS pathway has been a significant priority from my point of view, many wider stakeholders have understandably been balancing competing work streams and service pressures, which at times has impacted the pace of progress. The project has also required several iterations. Early testing highlighted that some questions within the form were ambiguous, prompting further refinement and streamlining to improve clarity and accessibility for service users. Recruitment challenges within the physiotherapy team have additionally delayed implementation and meant that we have not yet been able to deliver the anticipated Big Bang launch, although we hope this will be possible in the near future. Working collaboratively with an external digital provider has enabled further development of the platform, including functionality that will allow greater local autonomy in managing webinar details directly. Alongside this, ensuring full GDPR compliance required a change in approach. Although Eventbrite links were initially considered, this was identified as non-compliant, leading to the use of direct webinar links instead. As the project remains in its early stages, data collection and evaluation are ongoing, and further iterations are anticipated following detailed analysis. Despite these challenges, the project has successfully streamlined the referral pathway, enabling self-referral and empowering women and birthing people to take greater ownership of their pelvic health, while also aiming to reduce pressure on midwives, GPs, and health visitors. Next steps focus on completing implementation, progressing towards a system-wide launch, and continuing stakeholder engagement. Ongoing digital development, data collection, and evaluation will support further refinement of the pathway, ensuring equitable access and sustainable impact across the system. Thank you for listening. Apologies I'm unable to be with you in person. If you do have any questions, please do email me.
There we go. What a fantastic presentation. I'm just going to find my applause. It's such a shame that she hasn't been able to be here in person, because I'm sure there will be lots of questions, but I think it's a fantastic example of collaborative working, multiple stakeholders, competing challenges, and I loved her comments about it's her priority, but actually she's very aware that there are others in the system, and other stakeholders have competing priorities, and I think that's a reminder to all of us when we're working on our projects that it's wider than that as well. So I will open up if there are anyone wants to make any comments, or I don't know, Margaret, if you've got any updates on sort of launches of from what Rosie was saying, sort of the wider launch. But I think it's a fantastic example of project, but also kind of really ties into the one of the 3 digital shifts as well, moving from analog to digital, but and prevention as well for the future. So it really aligns with the long-term sort of plans for the NHS as well.
I mean, I think one of the bullet points about multiple requests for clarity and questions and improvements, probably me really. So apologies for that. I mean, the service has launched, but we have some areas where the physiotherapist has been delayed, and we're really optimistic that will be in place hopefully, or a decision made in the next couple of weeks. But you know, I think you summed it up really well. It has been a collective effort co-producing this with professionals and people, and to do it in a way that's very contemporary for the future, with populations that we work with now really. So yeah, but I mean, Rosie's been the driving force.
Brilliant. Thank you so much, Margaret. That's great. So that brings us to the end of our presentations and our webinar today. Thank you so much for joining. I hope that you've learned something. I certainly have, and I look forward to reflecting further on what we've learned to take forward into future projects. I'm just going to quickly share my screen again, just for our final evaluation. So I don't know if you can see that coming up now. Sorry, my mouse is not working. There we go. So thank you to all of our presenters for sharing your expertise and your projects as well. I'll pop the link for the chat in the, the link for our evaluation in the chat, and there's a QR code there. We'd love to hear from you, not only your reflections on today's webinar, but if there are any others that you've seen on our Futures website and you had any comments for those. And equally, if you've got projects that you would like to share for our future learning and sharing events, we'd love to hear from you. So thank you so much, everyone. It's been lovely to see you. Wish you all a very good rest of the day and week ahead, and hopefully see you next time. Thank you.